Technology Series, Fast Tracking Access to Care Through Technology. This is session number 2 of our events. We will have 3 and 4 listed for you shortly. Next slide, please. For those of us that are on, as you can see some instructions here around the logistics. Live captioning is available for those that need it. For the Q&A function, go to the chat line. Any questions, we will try to get to them during the course of our session today. And our moderator will be able to review them and then ask the panelists. If you run into any technical difficulties, just click the refresh in your web browser and it should come back up. If you have a problem with that, go to your telephone line and come in through the telephone line and you'll be able to listen to the event. Next slide, please. We are always excited about having new people join our chapter. If this kind of information is available to you on a monthly basis, please click join our chapter and be able to listen to these events during the course of the year. Next slide, please. Let me turn it over to our moderator, Elise Cole Grant, and she will introduce the speakers for today.
Thanks, Tony, and thanks everyone for joining the second session of our behavioral health webinar series, where we teamed up with HIMSS New York to really give behavioral health a seat at the table and talk about some of the really real situations that our behavioral health providers are facing on a daily basis. And as you know, we're really working, and the nation's really working on different ways to integrate medical health and behavioral health. So I'm excited that, HIMSS New York said, yes, let's team up with HIMSSNY and let's work with Elise to really put some onus and really give behavioral health providers and the behavioral health sector a place to shine. And today we're going to talk about fast tracking access to care through telehealth. And I'm super excited about the panel that we have today. We have 2, before I kind of introduce the panelists, I do want to give a shout out to our 2 sponsors. First one being DoxyMe. They are a telehealth vendor platform. And I even had the opportunity of working with DoxyMe in the height of the pandemic to work with them in providing discounts to our provider agencies during the time that they really needed it the most. And so here they provided some data where you can kind of see a breakdown of like rural versus urban usage for telehealth services. And I think that is a good representation of what is happening in New York, right? New York State, there's a lot of rural communities. And then in New York City, you have a very urban environment, right? And we're seeing telehealth being utilized across both regions. And so thanks so much, DoxyMe, for coming and joining us today. I'm really excited to have you guys on the panel and for sponsoring this event. Now, our other sponsor is Nutanix, and I'm thrilled to know that there is a vendor who wants to kind of be on a panel and talk about what's really happening on the ground level when this vendor is really looking at the back end infrastructure. So Nutanix provides cloud software solutions to improve the delivery and patient experience for behavioral health services, while reducing the IT operational costs. Now, oftentimes we talk about kind of what's sexy in the new environment in terms of technology tools, but we don't often talk about the infrastructure, the back end. And we know very well that if you are a medical provider, a behavioral provider, the operational cost is a huge burden. So where there's areas to reduce that cost and enhance kind of clinical workflows is something that our agencies, right, should take advantage of. So I'm really excited again. Thank you, Nutanix, for joining us on this panel session and for sponsoring this event. So with that being said, let me introduce you to the rest of our panelists. So I'm going to start kind of on the right and work my way to the left. We have Christopher Smith, who is from OMH. So we have some policy representation here. Really happy to see kind of and get his viewpoint of what happened during the pandemic and what we can expect to see as we venture on into this new way of delivering care. We have Lindsay March, who's from Family Services of Westchester, and we also have Heidi Waith, who is a peer specialist at Wellness Works Clinic Services for the Underserved. These are two providers that were on the that were really on the ground, working with patients, working with other clinicians, especially when the pandemic kind of first hit New York City hard. And I'm really looking forward to having them share their experiences of being really on the front line during this pandemic and what they kind of see and what we can sort of take out of it now that we're in this sort of new wave and new environment of using telehealth services. Not to mention, they are both part of the HIMSSNY network, so I'm really excited to kind of have some friends in the panelists. Next, I want to introduce you to Brandon Welch. He is the founder and CEO of DoxyMe. Again, like I said, I had a great relationship with Brandon right when the pandemic first hit, where we got telehealth licenses to our provider agencies. And last but not least, Joseph Wolfgram, who is also another sponsor, and he is the CTO of Nutanix and really looking at that back end infrastructure support. And so thank you so much again, Joseph Wolfgram, for being here. And, you know, with that being said, I want to give the panelists an opportunity to really introduce themselves. So Lindsay, why don't we start with you? Can you give us a little background on you and your organization?
Sure, absolutely. So I'm Lindsay March. I'm a clinic director with Family Services of Westchester, located in Westchester County, New York, FSW for short. We're a private non-for-profit agency that provides a multitude of services across Westchester County through various programs. We have therapeutic foster care, vet-to-vet peer outreach, elder abuse prevention, early childhood programs, just to name a few. The program that I'm affiliated with is the Family Mental Health Clinic. So FSW has 7 clinics across Lower Westchester that serves our communities by providing individual, families, couples, group counseling, as well as med management for those who need it. We serve clients of all ages from 1 to 100. And in the past year alone, the clinics have been able to serve nearly 3,000 residents of Westchester County. So I've been with the agency for about 8 years now and have experienced it both as a full-time clinician. And now, while I still maintain a small caseload, I'm involved in the hiring, supervising, and training of our clinicians and interns.
Wow, thanks so much, Lindsay. And we're really excited for you to be here. Appreciate you being part of the panel. And Heidi, could you give a brief introduction?
Hi, I'm Heidi Waith. I work with SUS, Services for the Underserved. I'm at the Wellness Works Clinic in Brooklyn. We're a certified community behavioral health clinic. So we're often referred as CCBHC. We have an integrated license with OMH and OASAS to provide person-centered care. The clinic offers an array of treatment services, including psychotherapy, medication management, substance use counseling, case management, and peer specialists, peer support, which I am.
Awesome. Thank you, Heidi. Again, really excited for you to be here and join us today. Let me kick it over to Joseph. Can you give us an intro?
Hey, thanks, Elise. My name is Joseph Wolfgram. I am the U.S. Healthcare Chief Technology Officer at Nutanix, and I served in CTO roles in large healthcare systems for the past decade before retiring in 2019. Last year, Nutanix came to me because they were looking for a CTO for U.S. healthcare, and I actually came back out of retirement because the success that I had with Nutanix and my healthcare organizations, where we saved so much money and simplified things and reduced staffing, I want to help as many other healthcare organizations have that same benefit. So that's why I'm at Nutanix. Excited to be here. Thanks for having me on the panel.
Joseph, you look pretty good for someone who retired. So I don't know, maybe you retired too early.
Maybe.
You're back at it. So glad. Thank you for joining us. And Brandon, let me kick it off to you. Oh, Brandon, I think you're muted. No problem.
Yeah, thanks. First, want to claim that I am a New Yorker. I don't live there now, but born and raised in upstate New York in the Finger Lakes region, and so I go back often. So it's great to talk to some fellow New Yorkers. I live in South Carolina now, but New York's always my home. So I left New York. I went and got an education, and one of the things I got was a degree in biomedical informatics, and so I'm a professor in biomedical informatics, and so I build software for doctors. And one of the things I built a few years ago was a simple and free telemedicine app. And I'm a professor at the Medical University of South Carolina, but I build technologies, and one of them that I built was DoxyMe, which is a simple and free telemedicine app that was rolling out. I had startups as I was doing my professor work. This one, as a result of COVID, got a lot of users, and so I've shifted a lot of my attention and focus to running DoxyMe because it's right now about 35% of the healthcare market, healthcare providers in the United States use DoxyMe. And so I'm able to have a great impact, and the stuff that we're building and doing with DoxyMe is exciting. And so I'm spending most of my time working on DoxyMe, but I have other things I work on as well, but it's primarily DoxyMe.
Yeah, great. Thank you for joining us. Way to strike while the iron is hot, huh?
Right.
And last person that I want to introduce you to, and I've known Chris for, I don't know, maybe 8 or 9 years now, always working on one program or another with him. So I'm really excited that he's joining us today. Christopher Smith, can you give us a little bit of a background on you?
Sure, happy to. I'm Chris Smith. I'm currently the Associate Commissioner for Adult Community Care at OMH. In that role, me and my team oversee all of the adult mental health programs licensed and funded by the Office of Mental Health. Housing, crisis services, clinic, PROS, ACT, and a whole lot more. So that keeps me busy. But during the COVID launch, I was transitioning from a New York City role to a central office role, and I started working on really kind of overseeing and coordinating all of our regulatory flexibility and telehealth flexibility to make sure that all of our providers and recipients continued to be able to get the care they needed during the pandemic. So looking forward to talking back about those days from a couple of years ago and where we are now. So thanks a lot.
Yes, thank you, Christopher Smith. And if you didn't get it from its intro, he's kind of an important person to have on your side. So that's why he's on the panel today. And with that, let me kind of kick it off. What I want to do is really set the stage real quick for this conversation is I'm personally very interested in the digital health funding trends, because I have a feeling that they sort of guide where we're going in terms of innovation. And this chart shows the last 10 years, actually now 11 years of the venture capital digital health funding trends. And you see back in 2010, it's very, very small. And in the last 4 years, it has skyrocketed. And if you look at particularly 2020 and 2021, you see that it's nearly doubled for kind of healthcare startup funds. And in 2021 alone, it reached over $30 billion of venture capital funds going into the digital health market. That is huge. Now, out of that $30 billion, 9.5 billion was for telehealth and around telehealth services and telehealth apps. So we see that telehealth is a pretty big deal, right? And we can kind of go back and see telehealth was happening before, but COVID really fast-tracked us into leveraging and using these tools, but also opening up service lines. So something that I know I work on with my agency, HIMSSNY, is we're looking at health equity and health inequities. And one of the health inequities is access to care. So we're going to talk a little bit today about how telehealth helps close the gaps on some of those health inequities in terms of access to care. In fact, we did a survey of the barriers to care and why individuals, specifically in the Medicaid community, individuals that are on Medicaid and Medicare, why do they miss their appointment so much? There's a lot of no-shows in our community, and one of the main indicator was barrier to care was transportation. And this survey was done in New York City, folks. So I can't even imagine what it would look like for the more rural regions where there's not as much transportation or people don't have access to transportation. And so I personally am excited about this. I think that telehealth is a huge way to close some of those inequity gaps. With that being said, we have seen that, there's been issues around it. Some people don't have access to cell phones. Some people aren't as comfortable with technology. Some people don't have a private place in their home or their shelter to have a telehealth appointment. And some people don't have the bandwidth, right, to leverage some of those telehealth apps. So I want to kind of touch on both of those things on both ends. And really what we're trying to do today, and what HIMSS New York has been so great in doing, is really giving behavioral health a seat at the table. I love this quote. I think I'm going to show this in every session as part of this behavioral health webinar series, that Shirley Chisholm, she actually represented a region in Brooklyn, and her favorite quote was, "If they don't give you a seat at the table, bring a folding chair," because I think that's what we're doing right now, where we're really giving behavioral health a seat at the table and, bringing attention to some of the things that we're doing. So with that being said, I think I've talked enough. I want to give it over to the panelists. So Lindsay, let's just kind of start from the beginning. Can you walk me through the situation of what it was like when COVID first hit? Clinics were shutting down. People didn't know where they could get their next treatment or where they were going to get their next medication. Can you kind of walk us through what that was like and what that looked like?
Sure, absolutely. So at the time things started closing down, I think like most people, we had no idea what the scope of this pandemic was going to be. Quarantine mandates had already started being put into effect, and we definitely saw an increase in our clients' anxiety, and we had clinicians that were out quarantining because of possible minor colds even, but they weren't able to access tests because they didn't have a known exposure, which at the time was the criteria to be tested. When we think about how far things have come since then, right? But there was certainly this sense that in the weeks leading up to the shutdown that our work was being impacted, and it was likely going to continue to be impacted. So by the week before the shutdown, OMH had already conveyed telehealth flexibilities that were happening in response to the state of emergency. Clinics were familiarizing ourselves with the new standards as well as online video platforms. So when the clinics did shut down March 16th, the day that will live in infamy, there was enough in place that allowed us to continue our work. There was, of course, the mad dash to figure out how to access all the information that we typically have at our fingertips, like intake packets. How do we help clients fill that out? Because most of our clinicians and clients don't have printers or scanners, and no one was going to Staples. Our forms weren't electronically fillable at that time, so we had to figure all that out. But once phone and video not only became an option, but became the standard, our ability to access paired with the dire need for support, it just exploded. I mean, everyone's lives changed so drastically and so fast. So if I compare the number of sessions in the 6 weeks leading up to the shutdown with the 6 weeks following, with the help of telehealth, our clients' ability to access our support and our clinicians' ability to continue working from home, we were able to do 1,500 more sessions in the 6 weeks after the shutdown than we were able to the 6 weeks prior. So just for some perspective, we did 35% more sessions in that time period than we had in the same time period the year before. So clients we were seeing once a month for maintenance work, they needed to be seen weekly. Some clients who we were seeing weekly, they needed to be seen more than once a week. And our cancellation rates just plummeted. They've never been so low. So we had to figure out, billing codes and if insurance companies were updating their coverage to pay for telehealth sessions, because many didn't before. Some insurance companies didn't even realize they now were being forced to pay for telehealth sessions. But we needed to assess clients' ability to access our care now. So did they have devices? Did they have internet? Had to troubleshoot privacy issues in homes. Now that everyone was home all the time, let's be honest, with prices what they are, families need to share rooms and have thin walls, and we had to figure all of that out. So, but I think despite our clinicians also going through that shared trauma and dealing with the same fears and losses and childcare stressors, they more than rose to the occasion, and we've only continued to increase our numbers since. So we continue to strive to serve more in our communities, especially now with the need so high. Wait lists across the board are longer than I've ever seen them. And it feels like everyone is in need because of the effects of the pandemic. And those effects didn't stop when things opened back up. I think people are still reeling from the long-term mental health impacts of the pandemic. And now more than ever, even more than the start of the pandemic, I think we need accessibility to mental health care. It's just vital.
Wow, thanks, Lindsay. I love the numbers that you shared, and I love how you kind of mentioned it went beyond just telehealth services. It actually forced you to kind of reorganize and restructure how you do everything when it comes to forms and intake forms, and really pushing you to like getting everything electronic, which I think sometimes the policies have to catch up with those as well. And so, yeah, you just like blew my mind with some of the things you shared. Heidi, I know that you're really, what you do as a peer specialist, you work very closely with the clients. Can you talk a little bit about your role as a peer specialist, and how did you maintain the care with these clients during that really pivotal moment where New York City was labeled the epicenter?
Well, for myself, for those who don't know what peer specialists do, we provide support with a rehabilitation and recovery focus. So we're designed to promote skills and managing behavioral health symptoms. So in doing that, then the pandemic hit, it was like, what happens now? People are coming in. We're used to people coming in. And for myself, I had just started at SUS Services for the Underserved in January. So, I'm just getting comfortable with my roster of my participants that I'm seeing. And now this pandemic hits and they can't come in anymore. What happens? Yeah. So what for me, I was already keeping contact with them, logs of when I meet with them. Now I was calling them multiple times a week. So, just to check in, making sure they were okay. And then you did have to deal with the issues of everybody's home now. You have kids home from school. You have no privacy. You have, people receiving care who may not be open with everybody else in the household. So what we did was just try to find a niche here or there for my participants. Like, okay, you can't speak in this moment. We were beneficial to say, hey, call me back as soon as you get an opportunity. I'm here for you.
Yeah. One of the, you mentioned that you called individuals, and I think when we think of telehealth, we always think about the video aspect, and we forget sometimes about the phone call aspect. And I know that OMH added to kind of the regulations that you could maintain just the actual phone call of the telehealth services, and you weren't required to have that video piece. And with that, I kind of want to loop Chris into this conversation. And Chris, you know, Lindsay mentioned that actually OMH responded like a week before the shutdown happened. I wasn't aware of that, but can you kind of walk me through that moment of crisis where you're on the other end of it, right? And what was it like, and walk me through the process of OMH signing that executive order?
So for us, we were in constant contact with all of our providers, hearing what they need, and trying to figure out what we can do as rapidly as possible to make change. If you've worked with OMH before, or any governmental organization, speed is usually not what we do best. There's a lot of bureaucracy. But for good reason, that there's not only state rules, but there's also federal rules. Mm-hmm. So, and OMH oversees pretty much the public mental health system. I mean, we're mostly working with people who are insured by Medicaid and Medicare. And, a lot of that we don't have control over. So we were doing this dance of what can OMH change, and trying to figure out what the federal government is going to allow us to do. So, but our focus at the beginning was really, number one, to ensure that the people who needed care could continue to get it as much as they could. And also we had no idea how long this would last, what the impact of this was, all of the things that Lindsay said. We were concerned with those same things. So our real focus was to make sure that our providers stayed in business. We didn't want everybody just to close their doors and not be able to provide services, not be able to get reimbursed for services, and go out of business. That was our biggest concern. And so I'll talk about some of the flexibility that we did. But it was also the other thing, which obviously was a huge impact at that time, was making sure people stayed safe. So reducing exposure, increasing social distance, and all of that. So telehealth was like the obvious choice to really be able to hit a lot of those areas, to keep people safe, to allow people to continue care remotely. But it wasn't the only thing. We also did a lot of things around billing flexibility. But just thinking about telehealth, you still, like, people weren't approved to do telehealth. And so, you had to be sort of approved. We had to sort of say, you can go ahead and do telehealth. So normally it's this application process, but we just said you can write a letter and attest that you're now doing telehealth. So we changed things like that. There's all these requirements around consent and HIPAA rules and confidentiality. So we talked to our counsel and said, okay, you can document it. You don't have to fill out forms, So we tried to identify like every type of flexibility that we could, and just rolled it out day after day. We had these FAQ documents where we would meet every day and like bring in the questions and answer them and run them through the agency and get them signed off and release them. And so it was just this constant flow of questions and concerns. But then on the other sort of billing flexibility that we had to do was because, people were adapting to telehealth. And so, normally you would have a 45-minute therapy session. What if you didn't have enough minutes? What if you didn't like to talk on the phone for 45 minutes? What if you're only going to a group? What if you're a program that runs primarily groups and doesn't really do much individual work? So we really adapted all of our billing rules to allow people to bill for shorter time frames and to do lots of other types of things like that, to really just facilitate people being able to provide the best services that they could, given the extremity of the circumstances. We gave other sorts of flexibilities around fiscal things. You could spend your contracts monies in different ways. We were like, all the normal rules aren't going to apply. So we really just opened it up for people to get by and do what they needed.
Yeah.
And a lot of that flexibility, almost all that flexibility is still in place. There were a few things that were federal flexibilities that we couldn't do. But so there was we always talked about, there's 3 different levels, like OMH could do some things, the governor could do some things through an executive order, and then the federal government could do some things. So we were having to balance out all of these 3 different types of flexibilities and keep them all straight and try and communicate them to everybody and try and make sure that they stayed in place for as long as possible. So it was really complicated, but it's actually very interesting. So I think I'm in the right job because I found it fascinating. I learned a lot about how all of these different systems work and interact. And I think providers had a greater appreciation for all of these different rules and things that nobody knew about. I didn't know any of this stuff before. And so it was just this really interesting time to do all of that. But and the one data point really kind of like similar to what Lindsay was saying, pre-COVID, like about 1% of our claims were provided via telehealth. It just hadn't really been adopted by the system. Granted, we didn't have all of the flexibility that we had, so it was a much more limited implementation. But there were all of these limits that it never would have been able to be as expansive as it became without really broadening all of these things and relaxing a lot of these federal and state rules. So we went from like 1% in February to 91% in April. And since then, it's kind of tailed off, but I think these days it's more around 70% of services are provided via telehealth. So people have resumed providing some care in person, which we think is very important.
Yeah. Wow. No, thank you. I mean, not often do we get to hear from your side of things and what it was like for you to navigate all of the different levels and layers and the, national regulations and the state regulations and then the various executive orders that were in play. Yeah. So I think it was actually, despite the devastation, I think New York really came together. I mean, the governor at that moment is no longer with us, but he said something New York strong, right? And I think it really showed that the providers and the state folks and the policy folks all really kind of got together to respond very quickly in this traumatic event. Now, Brandon, I'm going to kind of push it over to you. Is right now telehealth is available. All the providers are now like wanting to use it. And you had this mini little startup that was like this free telehealth services, and all of a sudden there's this high demand. How did you respond to that? I think you're muted.
Yeah, I keep forgetting about that. So yeah, no, it was pretty crazy. We started Doxme back in 2013, so it was way before COVID started, but we saw that the future was telemedicine. We knew that healthcare would eventually get there. It took a pandemic to get there, but we see the pandemic really shortened the time of telemedicine adoption about 10, 15 years down to a month or two. But pre-COVID, we had about 80,000 providers on our platform. So that's after 6 years or so, we had 80,000 providers. We're growing nicely, doubling every year, which was fantastic. And we knew it was kind of a niche thing, but slowly growing. If you're familiar with the technology adoption curve, it's those innovators and early adopters phase. But when COVID hit, we started seeing signs like 2 or 3 weeks before the shutdown that there was this trend. So we were already ramping up and adding servers because we saw the flood coming. We have colleagues overseas, and they were seeing the wave. The wave went from China through Europe and then to the United States. The folks in Europe were ringing the bell a week before people in the United States were. So we were already a little bit ahead of it, but nothing can really prepare you fully for what we saw. But it was pretty incredible. At the highest day, I think we had about 32,000 providers sign up in a single day. So we went from having 80,000 all time to in a single day, 32,000, half that amount sign up in a single day, and we were signing up 2,000 to 3,000 providers every hour at the height. Before COVID, we did about 250,000 minutes of telemedicine every day. At the height, we did 16 million minutes in a single day. And now we do about 7 to 10 million minutes of telemedicine every day. And so, and what's incredible is that we thought that there's this huge pop, a lot of people using us. I think a lot of people expected this as well. And then a month, the lockdown goes away and we go back to normal life and it's going to drop back down. But the longer this has gone on, the more people have just built their normal workflows, and the more like this is normal and it's expected. Patients now want it. They prefer. We often hear providers saying, yeah, my patients only want to see by video. They don't want to come in anymore. And so what we thought was just initial pop that would go away, a gas fires turn into a long burning solid flame, which is great. And it's great for the healthcare industry. And so before COVID, we did about 12,000 sessions a day. At the height, we did about 1 million sessions a day. Now we do about 300,000 to 400,000 telemedicine sessions every day. And it's, many people like y'all have come use it and there's been this lasting power in saying, hey, this is actually working really well. Let's keep doing it. And so our job is just to keep supporting that. And then the other big thing is international growth. And so we had Doxby was translated to Spanish or something at the start of COVID, but many people from around the world said, hey, we need this as well. And so now there's about 160 countries where we have providers, and we have Doxby in over 100 languages now because of the international need. And so, which a lot of those languages are in the US as well. So it's best of both worlds. And so telemedicine is, as many of you here are seeing, is telemedicine is really here to stay. And now it's all about optimizing workflows and being most efficient and effective.
Yeah, no, thank you, Brandon. And I am, such a dork that I actually, while Brandon was talking, I pulled up the technology adoption life cycle. I had this on one of my slides for folks that don't know what this is. It's how the market adopts a new technology, right? Oftentimes you have your innovators, you have your early adopters, and it's really hard to get from the early adopters to the early majority, and then the late majority, and then you have your laggards, right? Telehealth was maybe here in the early adopters before the pandemic. And now I think it's safe to say that we are now in the late majority where it's very heavily adopted and there's very few folks using or jumping on this kind of telehealth bandwagon, I guess you could say. So thanks for bringing that up. And with, that being said, when we see such a large adoption to telehealth, let me bring it to Joseph is, you are handling the back end infrastructure that no one really sees, right? But you have to support it. So how did you pivot to meeting like your customer demands and your customers being more, I think, the providers, but those telehealth vendors, right?
Yeah, it's a great point that you bring up, and to Brandon's point, there was about 10 years worth of progressive adoption that happened in a couple of months, a very compressed time frame. And anybody who's a healthcare provider today is now in the telehealth business in some form or fashion. But I'm glad that we're talking about infrastructure because there's 100% of the providers would be unable to provide telehealth if we didn't have infrastructure. I mean, it's not sexy, as you mentioned before, Elise. It's the video conferencing and the security of it all that is kind of like what people see. But in order for that to happen, you've got to have reliable and scalable infrastructure. Now, when I say infrastructure, those applications like Doxby or whatever telehealth app you're using need to run on servers. And they need to have storage to store files and data. They need to have really high-speed networking for it all to work well. Well, my company, Nutanix, we do hyper-converged infrastructure, which means we take all of those servers and storage and networking, and we consolidate it down into one small little appliance. And the software makes it so that it's super resilient, like it's hardly ever down. So it's always available when you need it, and it's easily scalable. So if we have a little demand today and a great demand tomorrow, our infrastructure scales very quickly. It's like bringing the power of the cloud into your local data center. And this is just absolutely perfect for healthcare organizations. And telehealth is a great example of that. So we didn't have to pivot much at all because our customers, Nutanix customers, use this hyperconverged infrastructure, and they were able to scale very quickly and easily. So millions of dollars gets poured into this back-end infrastructure that allow applications like telehealth, or even your PACS system or your EHR for that matter, to function. Mm-hmm. And if you have to scale quickly, sometimes it takes months to execute those kinds of programs, to upgrade that traditional infrastructure to get enough capacity for things to work. You know, with Nutanix, it's a simple click of the button, and it scales that way and just works really, really well for healthcare. And that's what it's all about. When I was CTO in healthcare organizations, I considered every dollar I invested, I was investing sick people's money. And I took that very seriously. And when I would see millions get poured into infrastructure that would sometimes not even get used, or wait to be used until there was enough capacity or enough users on it, you know, it's nice and refreshing to see something like Nutanix come into healthcare where you can just scale it quickly and very easily, and everything just works well and is secure. So, you know, that's the story.
No, thanks. Oftentimes we don't really hear about like the back end infrastructure. Think about it, right? Because we just expect everything to kind of run smoothly. So let me just stay on the technology piece for a little longer. Is we've talked about the past and how we got to where we are today. You know, and I'm going to ask both Brandon and Joseph, what does the world look like for your business now that telehealth is like a normal way of accessing our healthcare system? And Brandon, let's start with you. I mean, you shared some numbers, but you know, what does this look like for your staff? What does this look like for the provider community?
Yeah, so we recognize that we stand between the provider and the patient, and if we mess things up, we prevent providers from seeing patients, and that's a huge issue. Yeah. So we take that very seriously, and so first and foremost, our most important thing is to make sure that we don't interfere with a provider-patient relationship, because in person there's nothing that stands in between, and doing it remotely, we need to provide a service that they forget that there is something in between that. And if we have outages, or we're difficult to use, or complicated, or expensive, those are all barriers that prevent a provider from seeing a patient. So as far as like going forward and what do we look at, our number one priority is to make sure our providers have a great experience. And so we prioritize our staff in supporting our current customers. We prioritize automating support, fixing issues as quickly as possible, everything we can do so that people forget that they have us in between them and their patient. And that's our number one focus. If we take care of that, then everything else will fall into place.
That's great. You remind me of one of my marketing professors at NYU said, you know, we don't sell products, we sell experiences. Yeah. And that stuck with me customers don't buy products, they buy experiences. And I think you just explained that. And, you know, Joseph, you were speaking to that, right? Is that you had already set up your solution so that it was kind of easy to scale. But what are some of the things that you're doing differently now that we are sort of in this new environment where telehealth is a big service, but also just like technology dependency is so much more now than it ever has before?
Oh, absolutely. And, you know, first I want to say, I believe wholeheartedly that telemedicine, telehealth is here to stay. We're not going backwards from here. People have realized how efficient it could be. You know, Heidi mentioned how many more clients they could see, and Lindsay rather. And it's just, you know, we're not going back from that, sitting in the line in the doctor's office and that sort of thing. And, you know, it's the same for remote work. We're not going to all go back into the office immediately either. There are too many advantages to the way human beings are meant to live when you can do things remotely that we used to have to commute for and all that kind of thing. So what we've seen differently, you know, since telehealth is here to stay at Nutanix, is that the healthcare providers have had such a great experience with scaling up this telehealth application, which is truly challenging. I mean, it's full video and audio and real-time communications and stuff, that we've seen huge adoption starting to happen in other places like PACS imaging systems, the electronic health records system, and things that are really critical to the business, because when you have infrastructure, that is easier to manage. You need fewer staff resources to support it. And that means more money, more healthcare dollars available for things that really provide true value to patient care. So we're seeing huge adoption in other areas of healthcare with a hyper-converged infrastructure from Nutanix because it works so well in telehealth. And you know, the more healthcare systems that emerge as critical to the patient care that really rely on vital infrastructure, the better our business looks at Nutanix, because we're the leader in providing software-defined cloud capabilities to the data center, and it's a perfect fit for healthcare needs.
Yeah, it kind of goes back to what Lindsay had mentioned in the beginning, right? That telehealth was sort of a Kickstarter to looking at all applications and how we can enhance workflows on the electronic end in terms of forms and assessments, because people just couldn't access paper like they used to. So thank you. Now, I want to bring it back to the patient, because we're all doing this for the greater good of the patient. And, you know, Heidi, how are patients, consumers now responding in this new world? Do you feel like this is a setback for some? Do you feel like we're mostly progressing? Like, from the patient end of it, what's going on?
Well, for SUS, since we prioritize person-centered services, we provide services in whatever way our participants, you know, they prefer. So if it's in person, by video, in the community, now that we're pretty much hopefully, you know, it's been 2 years, but where we're at now. So as long as we can continue providing the person-centered care for our participants, they respond well.
That's great. So you have, do patients feel like they have now more options to access care?
They do. They do. They haven't really experienced setback. Despite the challenges that were created by the pandemic, they have remained resilient and continue working through their recovery, you know, and how, like I said, we meet them where they are.
Yeah.
So if it means a phone call, okay, if it means we're coming out the pandemic and getting back into the community, and I'll come meet you and escort you somewhere as a peer. So I'm going to escort you to that doctor's appointment or to that insurance appointment so you can feel comfortable being back in the community in the times we're in. That's what I'm here for as a peer.
Yeah, I think that's really powerful, because I think that, you know, there's been now a lot of new care models that incorporate peer specialists, but I feel like the larger community and the medical community doesn't fully understand what a peer specialist does. So if I can just kind of repeat what you said, is you actually meet people where they are and like escort them to services, escort them to, from what I understand, maybe a job interview, right? You're like their cheerleader in the background. And even, you know, I've heard from a patient that coming out of a psychiatric unit and going to the grocery store was so stressful for him. I mean, he just he couldn't even imagine shopping in a grocery store, being around all these people, having to figure out the items, having to figure out how to pay. So I know, you know, individuals like yourself, you help those patients really do that and incorporate them back into the community.
Yes, and what I really stress to a lot of my participants is the non-clinical portion for myself. Yeah. So I can express to them, I'm similar as you. I receive services. I could be transparent to say, hey, I need somebody to talk to as well. There's nothing wrong with it. And as well as, like you said, the community really doesn't know what peer specialists, what we do. So sometimes we're not receptive. So I let them know, no, I'm here to advocate for my participant. And I let my participant know, you have every right. Express yourself. What you don't remember, I'll remember for you. So I'll go over something with them prior to a visit. Well, what do you need to talk to your doctor about? What do you need to get out of this appointment? And then I'll let them take the lead, and I'll say, okay, Miss Jane, oh, do you remember you said you didn't remember the doctor wasn't here and you said you needed this prescription or you needed this appointment. So that's what I'm here for.
No, thank you. It's really, really powerful to hear. So I'm gonna jump over to Chris because I know Chris has to leave us at 1 o'clock. He has a meeting with the commissioner, and I know he's gonna tell the commissioner about this panel and advocate on behalf of all of us for to increase and enhance and maintain the telehealth services. So thanks, Chris, for that. So, you know, there's obviously a lot of pressure and excitement to make telehealth remain accessible for those in treatment. Can you shine some light on as to where OMH and maybe DOH stands in what is the future of telehealth now in terms of like service reimbursement and all of that?
Sure. Definitely. And also, I didn't mention this before, and when Heidi was talking, it made me think about it. We were very aligned with OASIS, the substance use state, our sister agency. And, you know, we've been very much in lockstep about how we're going to move forward with the telehealth flexibilities we already offered and what we're going to maintain going forward. So just to be clear, we've already passed revised telehealth regulations. And so all of the, I mean, I can't say all, most of the flexibility that we offered during the pandemic is still in effect due to a commissioner's waiver if it's not effect in the regulations. So we really see the benefit of telehealth. We want to open up access. We want to give people choices. And I appreciate very much what Heidi was talking about, SUS's approach of being very person-centered, because that's really our expectation. Like sometimes we'll hear from a program that says they want to offer 100% virtual services, only telehealth, no in-person. And we say, no, you can't do that. Because we work with people who are in poverty, who have so many deprivations, so many barriers in their lives, and people who can be quite ill and who can go through a lot of changes. And sometimes they need to be seen in person. Sometimes they want to be seen in person. Sometimes they want to be seen. They want to have a telehealth service. So we expect all of our providers to really meet the people where they are and develop a plan with them individually for how telehealth will fit into their service array. That being said, some of our programs like inpatient and CPEP emergency services, those are really in-person services, right? You can't be on an inpatient unit from your house. So, you know, telehealth is going to have a much more limited role in those kinds of services, more around consultation, but you'll still have to have the kind of core in-person team in place, but you can supplement that with remote services. For ACT, which is it's an in-the-community service. It's for people who don't like or don't do real well in place-based services. So for those, you got to see them in person. And I mean, you don't get on an ACT team if everything's easy for you. So you need people we think people on ACT need people to come out and work with them in person. So while we're having this broader approach, like I said, around person-centered care, we're in the process of developing a program-specific guidance where we'll be kind of highlighting for providers along the lines of what I was talking about. You know, if you're in a group program, it's going to be harder to do, remote groups and mix it up with in-person and remote. So, so you're going to have to think about how to do that. So we're looking at releasing that. We're finalizing it right now and get it through our approval process, and then we'll release it. But the other thing I wanted to mention is we're keyed to the federal public health emergency, right? So there's a lot of the things that we're doing. I was talking about the billing flexibility we were able to do that due to a federal waiver, and that's going to end when the public health emergency ends. So a lot of the billing flexibility that we've offered is going to go away then. We put out a memo last October. I don't know if anybody read it, but if you didn't go on our website, it's still there, telling you what what we know is going to go away at the end of the federal public health emergency. It's some of the documentation flexibility that we've offered and a lot of the billing flexibility. And that's stuff that we really don't have control over. It will be going away. And so, that's where we're at right now, is really trying to and it looks like, we don't know, but it looks like this may be the last extension of a public health emergency. We don't know. It may extend further, but it's hard to imagine politically and sort of where we're at in the pandemic that we're going to get another 3 months out of it, but we might. But we're expecting right now, and I have no insight into the federal government, so that this is certainly, don't bet on me being right on this. But that's what we're planning for, just so we have a goal, is we're expecting that the federal flexibility will end in July. And so we're trying to get out guidance and advice to providers leading up to that, so people can start getting ready for how to adapt once the federal flexibilities end. If we get more time, that's great. We'll have more time to make those transitions. But like for the telehealth front, as soon as we get that guidance ready, we're going to release it. So if we have more time, we'll have more time to adapt to it. So that's really where we're at. And we've been continuing to talk to providers. We're also looking at so and a lot of stuff we don't know we know the access, how that's been helpful. We hear stories and anecdotes about some people who do not do well with telehealth and really need that kind of engagement. People who end up getting hospitalized a lot more, or there's suicide risk is a big issue. Violence risk can be a big issue, and so we need that engagement and sometimes that sort of eyes on with people to make sure that they're doing well. Because what they may say may not reflect the reality. So, while we fully support audio only, sometimes you need a video visit if they only like telehealth, just to kind of take a look at them and see, have they lost a lot of weight? Are they doing okay? And then, when somebody's getting discharged from a hospital or released from jail or something like that, maybe you need to bring them in for an in-person visit to kind of check on them and see how they're doing. So that's really our expectation for how all of these pieces should sort of fit together, with those caveats that there's things that are not under our control that will be going away. But telehealth, most of it that we've already done, if it's under our control, not federal control, will stay in place, at least for the potential. Not for everybody. Everybody needs to be making the good decisions, the good person-centered and clinically appropriate decisions about each individual that you work with.
Yeah, and from what I understand, there is a lot of advocacy going on the federal side to try to make sure that these telehealth services are enhanced or maintained to a certain degree. We'll see what comes out of that, but I appreciate you being very clear about it, because I did not read whatever you had put out last October.
Of course you didn't. We only put out 15 zillion memos during COVID. One of the things, though, the federal things, there's a for when people are prescribing controlled substances like medication assisted treatment, but also stimulants or anxiety medication. Under the federal rules, you have to see somebody in person first before you can then follow up via telehealth. That will go away unless some federal legislation is changed. Yeah. So we're working on, just advising people, hey, this is probably coming. You need to start figuring out how you're going to kind of catch up with this and keep this going moving forward. So there's some of these things that are out there that we already know about. So that's again where we're at right now, is trying to identify things and highlight it for people so they can start planning for when some of these flexibilities are no longer there.
Yeah, thank you. And I know you got to jump off in 2 minutes, so really appreciate you being with us, Chris. Folks, we're going to continue this panel discussion. We actually have until 1:30. We're going to continue this conversation probably for another 10 minutes or so, and then open up the line for questions. So I hope folks in the audience don't go anywhere, but thank you, Chris. Now, Lindsay, I want to kind of respond to what Chris just shared and ask you one, this is a new norm for providers now, right? It's telehealth. And almost as a response to what he shared, what are your providers, your clinicians, your staff members feeling now that this is the new norm, and that also things might change in the near future?
Yeah, absolutely. I mean, I would say that we have certainly found our rhythm to a hybrid approach to providing services. I think like most things in mental health, telehealth is not a one-size-fits-all approach, and it certainly does not solve all of our problems. So we're very aware that of our clients and families, like we've said, who have limited access to devices or internet, people who are not maybe technologically savvy, some of our older populations, but with that continued ability to provide phone sessions or audio only sessions, that's certainly helped us continue to access these often underserved populations. I think one of the difficulties that we face is ensuring that the flexibility that's offered through the option of telehealth does not negatively impact the quality of our work with our clients. So just because it's feasible does not mean we are doing sessions in a car while the whole family is out running errands or in the middle of a playground. So it's also not an approach, you know, like Chris said, it's not an approach that benefits everyone. Some people are better coming in person. So it's been really important for us to also preserve the parent participation in sessions. You know, we're able to now access kids earlier in the day because we don't have to factor in a commute time once they get home from school. But we also need to remain mindful that parents might not be available at those times. You know, some parents can take a late lunch or stay in the office late and join a telehealth session from the office, which is amazing. But for others, that's not feasible. And, you know, not including parents in treatment is just, it's just not an option. So, you know, but with all that being said, I think telehealth has also opened up doors that we can't imagine closing at this point. Our prescribers are able to access clients across all of our clinics, often regardless of location. Our virtual groups are now open to clients across all of our clinics instead of only open to those where the group, close to where the group is running. We can access clients who are on vacation or who are home recovering from surgeries. We can see the working class on their lunch break. So, you know, and our clinicians can be home with a sick kid and still work from home if they choose. So, you know, they can schedule a break in their day and participate in dinner with their family, or set their kid up with their tutor and then hop on and squeeze a session or two in the evening. So, you know, just the other week I had a dentist appointment, and instead of having to take a half day, I was able to schedule my clients a little bit differently, took a couple of hours off for the appointment, and then was still able to see all of my clients and have all of my supervision meetings. My day wasn't impacted, you know? So, you know, we've really been able to reduce our need to cancel, which has increased engagement. And we've also been able to increase our engagement as providers in our own home and with our own self-care practices, which has been huge and is only beneficial to our clients as well. When we're in good shape there, you know, we're better for them. So, you know, I think we hope that we can maintain this level of engagement with clients. You know, we have to remain mindful of changes in policies and regulations, like Chris said, but we also have to remain mindful of insurance companies' changes. You know, like Chris mentioned before, previously there were a lot of restrictions, one of them being insurance coverage. So, you know, now some companies have waived copays for telehealth sessions only. I mean, talk about reducing barriers to treatment. Don't even get me started on copays. But will the reimbursement rate be reduced by some insurance companies for telehealth appointments? Like, that would certainly impact our ability to do the amount that we're doing now. And we just don't know. You know, like Chris said, we don't know what the future holds. So we're just going to keep doing the best we can with what we have in front of us and prepare as best we can for.
Yeah, I know that's a huge question with the providers. Are we going to get reimbursed less for telehealth services, right? And it's a huge conversation because I can see arguments on both sides. I mean, you're providing the service, so the service should not be discounted just because it's over telehealth. And also you have the license fee associated. It's more expensive. But then to your point, you can also, there's a lot more flexibility where you can like have, you know, appointment by appointments and scatter them throughout the day. And you mentioned it didn't impact your schedule, also didn't impact the patient's day, right? Because they could still see you. And sometimes it's like one or two words that could really save a patient's lives, because you guys are dealing with individuals that have severe mental illness, right?
Absolutely. And going back to like what the need is now, I mean, the need is just greater than ever. So the thought of reducing, you know, taking steps back and reducing access is just it's not the right time for it.
Yeah.
I don't know if there's ever
and I
a time
appreciate
for it, but
yeah, and I appreciate you highlighting some of the engagement trends, like opening up group sessions for other people to join. Heidi, can you, are there any other engagement trends that you've done with SUS related to kind of different technologies and related to telehealth, where you've been able to further increase the engagement to patients?
Like Ms. Lindsay has stated, the opening of groups. So I run a group, a creative journaling group. So sometimes when participants aren't able to come out, we've gotten them on Zoom.
Wow.
To participate. And if Zoom doesn't want to act right, get onto the phone with the telehealth and just have them engaged in this service, because it's something, you know, they won't feel alone.
Yeah.
And just help them all around.
Yeah, that's really cool. I think those are things that we don't think about every day, right? A creative journaling group or a group therapy session, or like just even like a community session where you can just go and join. Because oftentimes I know these individuals feel really isolated. And if they can join a group and see other people or hear other people's voices, I know that it makes a huge difference.
It really does. It really does. That's true. It's like for my creative journaling, like for the participants who don't get out, who can't exercise, we have upcoming plans. Like during my group, come on out. We exercise in my group. So like even the people that are at home, we have a regular trend that we do. We start open our group. We give a word of encouragement in my group at the beginning of every session. So if people aren't there, you still have to give a word of encouragement. If you're not mobile, I have a particular participant. You're in charge of doing the exercises and the stretches. And when I forget them, they'll say, oh, but we didn't do this today. So, and soon the weather's getting nice. They want to go walk around the block. So, you know, this really opens up the engagement for them to be able to, you know, kind of get back maybe into what's going to be the new norm for them.
That's great. Maybe I can join one of your exercise classes that you
It's about the only exercise I get sometime during the week. I tell them, I'll be like, oh, yeah, I didn't exercise today. So, yeah, you're welcome anytime.
That's awesome. That's awesome. So I want to get one more question in before we open it up to the audience. And Brandon and Joseph, we've heard, you know, what's going on in terms of the engagement trends. Maybe you guys could kind of open up your hood and give us some little secrets of what's going on in the innovation front on your end. Are there any product enhancements that we can look forward to, or what are you kind of working on? Joseph, I'm going to give this one to you first.
Okay, I'll keep it brief. I've just loved the conversation today. It's such an important service that's happening, and this is why technology exists, in my opinion, is to increase the community and the connectedness, and not to isolate us further, which can happen in some social media channels. But this is a fantastic use case. So, little under the hood, what's going on next at Nutanix, premier provider of hyper-converged infrastructure? I think it's all about flexibility of moving services like telehealth and important workloads, PACS and EHR, between your data center and public cloud providers. Now, public cloud is a lot in the conversation these days, and there's a lot of enticements out there to get healthcare providers to use, you know, public cloud, AWS and Google and these folks. But it can be fraught with challenges. There's a lot of hidden fees and escalators and things that aren't apparent at the front of those contracts. So healthcare providers need the capability to be flexible and move things into the public cloud when they need to, and then move them back in easily so that they don't incur unreasonable costs. And I think our technology allows them to do that one-click move of these workloads between their local data center and these big hyperscale public cloud services. That helps us keep costs under control and maximum flexibility and scalability for healthcare providers. So I'm excited about that.
Thanks. Yeah, thanks for sharing. And Brandon, you're up last. Is, you know, can you like take us under the hood? What are things that we can expect out of DoxyMe or your other companies in terms of the innovation front? You're muted again.
There's a reason for that, because I have the door open and cars go by and they're noisy. So I, you know,
well, I see you're on a bridge, so it must get really windy,
yeah,
you know?
I wish. No, so we look at the world and healthcare, especially now in this post-COVID era. There are things you can do in person that you can't do remotely, but there are potential of things you can do remotely that you can't do in person. And we can never replicate, we try to replicate as much of the in-person care as possible, but you just can't replace touching and feeling a patient, right? But when you get to the remote space, we have audio and video going through our system that doesn't go through a system in person. So what we want to do is like leverage the advantage that we have with remote care and do things that are not possible to be done in person. We're going to try to do that remotely. So for example, we are working on closed caption and transcription. I mean, that you get that in Meets and you get that in Zoom, but we're going to take it to the next level and say, look, we've got the text going through our system. Why don't we use natural language processing? We know it's about a therapy visit or a doctor visit. Why don't we structure those notes into a SOAP note or some type of notes so that the provider doesn't have to go home and retype her notes at the end of the call, but we can take all the text that's going through all the audio, turn it into a text, and then structure it into notes so the provider just says, oh, great, here's my transcript, all structured notes. I can copy and paste that into my EHR. So there's some cool stuff there.
You got Lindsay really excited. She perked up
yeah,
there when
right.
you said that.
I was gonna say, if you can reduce the documentation point of stuff, I'd be in heaven.
No, that's exactly, because we know that providers, and that's a huge time suck. And
Yeah.
a lot of other things like patient intake. You know, when you go in person to an in-person session, you give them a clipboard and then they fill it out in the waiting room. They give it to somebody at the front office and they go and retype all the information, or a medical assistant or nurse has to retype all this information. A lot of that stuff is like easy to collect and can be automated. So we have another technology called Docbot, which is a chatbot that automates the collection of patient assessments and intake forms. And so when a patient checks into Doxy.me, you can trigger a bot to go through, collect all this information before the call even starts. It doesn't require a human to collect and give a clipboard and collect this information. We automatically collect it and then give it to the provider. And so we've got the bots, the assessments, automatic patient reminders. So during a call or during the middle of a call and the doctor says, oh, I'm gonna have to prescribe you some Ambien or something for whatever you need. It's listening to that and it detects, oh, Ambien, great. And then it pulls up an e-prescription module with Ambien filled out, ready to set the prescription. So it's like using the text and the audio and the video that's going through our system and then just taking a step away from the provider that is a manual process for them, trying to automate as much as possible. And then we're always trying to make things easier and more accessible. So there's no downloads now. There's nothing you have to set up, no hardware. And so it's super easy to use, but still in a lot of rural areas, if the internet's not as good or it's kind of choppy, it's kind of like, how can we help with that, right? So we're looking at things like getting a module, we call it the Doxy box, but it sits on top of a TV. So if somebody doesn't have a computer, you plug in the Doxy box into a TV, and then you use the TV as the Doxy screen. So you could sit on the couch watching TV and flip from Maury Povich over to a Doxy call to see your doctor, and then back again. So it's
and they go right
the
back
doctor
to
in the home.
your TV show.
That's right. It's another TV show. And then the other thing is we actually got a grant from the government to build Doxy.me into VR. So patient and provider will be able to use one of these and do a virtual call, literally virtual call in a virtual world where you go in, it's all VR space. You can see the doctor and the patient and you guys chat. So there's a lot of cool stuff, but it's like, what can we do that we're not taking advantage of that? Yeah. And all these things I just mentioned, you can't really do in person. And ultimately what we want to create is that the remote experience is better than the in-person experience because there's so many more. It's like shopping. Like, who loves shopping at Walmart? No, you go to Amazon and everything's there and it's easy and it's one click and boom, it shows up at your door and the next day. Like, that's the type of experience we're trying to create at Doxy.me, so that when there's an option even for the provider and they say, do I want to meet with the patient in person or do I want to do it remotely via Doxy.me? They say Doxy.me is better because it's got all these awesome things. And trying to do it in person, oh, I missed the notes and I missed the transcription. I missed everything else that the remote care offers. And so that's innovation that we're creating.
Well, thank you. I mean, that was really great. And I think, I see a lot of my fellow behavioral health agencies that I work with across the network in the audience today. And I think it's so important for them to hear from both of you, like what's to come and what is possible, because I think it's so easy to get stuck in like, our workflows and get flooded with paper and trying to go from system to system to system, that it's nice to hear of like what's coming down in the future, because then it gets providers thinking like, oh, what are the possibilities? Let me try to like advocate and talk to our department to see if we can look into getting patient text message reminders, or, simple things that actually like don't exist really in our workflow today. So it's really great to kind of hear the possibilities of the future and what you both are building. And also thank you, Heidi and Lindsay. You guys are rock stars. Just know, like, when New York was clapping at 7 p.m. every day, I was clapping for all of you. And that includes like the case managers, the security guards at the housing shelters, right? Like all of our real frontline workers. It wasn't just the doctors, right? It was you guys. So thank you so much. And with that being said, I want to open up questions to the audience. I know that I think we're going to have someone handle the questions, and we're getting that together. I just want to share this one slide. You heard Tony, the president of New York HIMSS, talk about it, but since I know that I have a lot of individuals that I know in the audience, I definitely recommend that you guys become a chapter member. I think it's like, Tony, is it like $30 or $60 or something? I forgot what it was. What's the price to become a chapter member?
Chapter member only is $39 for the year.
$39. This is something that I bet you your agency honestly like might even pay for you to do. The reason why this is important is there are so many resources that HIMSS provides. I'm talking about any type of white paper you could ever think of, like access to all of these different events, and like access to, free events that are happening, also different conferences that are happening. And previously or historically, it's really been the main audience has been the physical and medical communities, but I really think it's important, like, let's get some more behavioral health providers to show up at these HIMSS events and make yourself known, so that way, they get national coverage. So ONC, CMS comes to these events, right? And they see people present. So the more we can kind of get a seat at the table, I think we're gonna, see kind of changes in different care models and funding models that are happening. Anyways, that's my like little spiel. Tony, did you want to add anything to this?
Not really, but I'm always looking to have new volunteers join our groups. So if anybody is interested, come and take a look at the New York HIMSS website. We have multiple committees that are out there, and maybe there's something that fits everybody.
Yeah.
Let me also mention, coming up, a couple of other new virtual events that we have coming up on Saturday, May 7th, for all our nurses out there. We're doing a nursing symposium from 9 a.m. to 12, and we'll be offering 3 CEU credits for them. So any of the nurses out there, they can kind of join. And then on May 10th, our next installment on merger and acquisitions will be held at, and I believe it's 12 o'clock noon, but again, go to our website, take a look at the events that we have planned.